Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon and thanks for your company. Well, this evening our programme focuses on headache, neck and back pain, including migraine, torticollis, cervicogenic sinus and cluster headache. We'll hear from Professor John Murtagh about the management of chronic back pain, and we'll see a demonstration of some physiotherapy pain relief and prevention techniques. So let me jump straight into it and introduce our panel for this evening's programme. Dr. David Jamieson joins us again to chair our discussion tonight. Welcome back, David. And with him, our physician, Dr. Tony Ryan, head of the Department of General Medicine at Fremantle. Tony, welcome to the programme.
Thanks.
And joining us also is physiotherapist Declan Coburn from Rivervale Physiotherapy. Welcome along, Declan.
Thank you.
Well, between them, Tony and Declan should be able to field most of the questions you might have about head, neck and back pain. So if you want to ask a question now or at any stage in tonight's programme, please give us a call on 1800 673 277 or 08 229 5241. So, David, let's kick it off with back pain.
Great. Thanks very much, Jay. So perhaps we should start with the typical medical start with the history. And what would be some of the more important points of a history of someone presenting with a low back pain, say, for instance, Tony?
Well, I guess it's the initially the location, trying to localise it to the muscles or to the spine itself, but also the duration, how long it's been there, and acute on chronic, and then whether it radiates, the severity, and also whether it's mechanical or whether it's inflammatory. Just the standard questions, whether it's worse in the morning or worse in the evening, whether it changes in weather, and then you can usually sort of narrow it down whether it's sort of going to be a musculoskeletal arthritic condition or an inflammatory condition. And with the background of always not forgetting malignancy or infection, because they're the sort of things that get missed.
Yeah, sure. If it came to an examining the patient with, if you had a referral through for somebody with say a 30-year-old man with a back pain that was perhaps going into his buttock a bit, what would make you more concerned that there was something underlying, Declan, from an examination point of view?
Sort of peripheral radiculopathy or somatic referral into the buttock or into the lower limb would play a key role in asking further questions. We'd be looking at the mechanism of injury, plays a sort of indicator as to whether we're going to look at whether it's going to be an articular facet joint sort of issue or whether it's going to be a discogenic issue. So when we're doing our subjective history, if a patient has a poor sitting tolerance, then that can be suggestive of a discogenic injury, comparative to, say, mechanical, as touched on before, going from a sit to stand, where there's a catching pain, which could suggest more of an articular problem. And that would then lend our sort of point of focus to the objective assessment, where we'd look at those as being, to narrow it down to like an articular or discogenic problem.
How often would you say you felt that there was more of the worrying, from presentations to your practice, say a musculoskeletal, an injury that's going to get better compared to the more worrying nerve compression type injuries that might need some other type of intervention? You've got a rough...
How many are more serious?
Yes.
Probably the majority are musculoskeletal that
Sure.
we'd see. So we're probably looking at maybe about 80% of our caseload would be straightforward articular discogenic, but then with the occasional that need to go on into more further investigations, such as more severe disc bulge, which is compressing a nerve root.
Sure. And from an investigation point of view, Tony, how would you like to sort of break that down?
Well, everyone thinks about x-rays, but the evidence are that back x-rays in acute back pain are fairly useless, and you're better off relying on the history and examination in that setting. As a routine, you should, when people are not getting better, you always have to think about doing a full body count, ESR, calcium, alk phos, and that's a good general screen. And then later on you might, as I said, if it's an inflammatory condition, then you're going to do your rheumatoid screens, autoimmune screens. But most, as Declan alluded to, most back pain it will settle down. It's musculoskeletal, and there's also good evidence that people should be mobilised quicker. I mean, traditionally people used to sit in bed and lie for 2 weeks, wait till it got better. But in fact, it's the complete opposite. All the studies show that early mobilisation improves recovery quicker.
Do you think there's any role for bed rest at all in a patient with acute back pain?
It could be argued that where there's significant trauma, that the initial immobilisation may be beneficial to prevent continued disruption to the surrounding tissues. But realistically, early activation is probably the best to reduce the risk of things like reflex inhibition of the deeper muscles within the spine, and therefore to control the healing process so it doesn't become protracted by immobility.
So perhaps initially we're talking a few hours or a day or two?
First, 24.
First 24 hours,
Basically,
and then get them up and try to get them moving.
As active as possible, yeah.
As active as possible, okay. Well, perhaps we might at this point go back to you, Jerry.
Sure. Recently, Professor John Murtagh was in Perth, and our colleague Olga Ward caught up with him and asked him to share his experience and knowledge in the area of chronic back pain, including both the management of the pain and the management of the patient.
John, welcome to the program.
Thank you, Olga.
John, one of the things that GPs see a lot of is patients with chronic back pains, often many years standing. Could you give us some ways of approaching them, and especially when they're on a load of medications?
This is a very big problem. It's something very dear to me, having spent a long time in rural practice where these problems are rife. The chronic back pain problem, the people who are on all these nasty opioid drugs, the Panadine Forte, all these drugs which really just seem to go on and on. I think what one has to do is to try and wean them off the drugs if you can. It is not easy, but there are various strategies you can use, and there are some that have been used successfully by some people for a while. The only things which are proven on evidence-based medicine to help backs is mild analgesics, such as paracetamol, keeping active, doing exercise, and also what they call the heat packs. Heat packs have been shown, in fact they call them heat wrap, and a heat wrap is where patients are able to put this object around them, which maintains a lot of heat around the low back. So those things have been shown to help them. So I think we've got to try and get back to these more basic, simple things. So what I try and do is get the patient off the opioids and the nasty drugs, and give them the reason why. You've got to sit down and explain why you do this. So you say you just want to get them onto paracetamol. You get them to keep active. You get them to do exercise. Now, if you're lucky enough to have a allied health professional, such as a really good physiotherapist, who can teach them exercises, who can give them mobilisation or physical therapy, or teach them Pilates or Feldenkrais, just to get their mind off their pain and to be focusing on improving their posture and getting their back supple. That is a very good strategy.
A lot of the patients are coming back from pain clinics with another cartload of medication. Do pain clinics also subscribe to this sort of philosophy?
Well, the pain clinics often have an anaesthetist there who gives advice about injections, and they may have someone who is organising acupuncture. Now, these things are all right. I mean, the TENS machine, acupuncture and spinal injections are okay, but the evidence is not good for them in alleviating their pain. They may be only band-aid measures. What I try and do is what is a trick which was devised by a very famous New Zealand GP, and that is, I say to them, look, we want to get you off this medication, and you make a pact with them that they want to get off it too. So you try and just keep them on paracetamol, and then I usually put them on amitriptyline, good old triptanol, particularly at night. You start off with, say, 25, 50 milligrams at night, and you say you're putting them on a drug which you tell them it's an antidepressant, it's to help the nervous system, and you point out to them that it can help people with sciatica, and you then gradually bring in amitriptyline and you try and phase off the opioids. And quite often you get excellent results. And one of the reasons why we have found we get excellent results is because a lot of these people with chronic pain are depressed. So you're treating their depression, and the amitriptyline, as you know, helps it's neuropathic, so it helps any referred pain or sciatic pain. So that's what I try and do. I try and bring them in with amitriptyline and wean off the opioids. Another thing you can do, which has been shown to be effective, is if the person has evidence of inflammatory pain, in other words, the pain is worse at night, I think it's worthwhile putting them on a solid course for 3 or 4 weeks of a non-steroidal anti-inflammatory. And I like to use one of the newer ones. And then see how you go with that. Because sometimes when they take it religiously for 3 or 4 weeks, and the inflammation settles down, you can then just rely on paracetamol better.
If you're trying to wean these sorts of patients off opioids, and I'm thinking particularly the ones that are on MS-Contin or slow-release tramadol rather than lodopanidine forte, what sort of timescale are you looking at? Do you wean them over a month or 6 months or a year?
6 to 12 months is that. Sometimes you may never wean them off it, but that's what I try and do. First of all, my first objective is to get to 6 months, and then I might, if I feel we're sort of winning, I'll extend it to 12 months. But that's the sort of time frame you're working on.
And the psychological and the physical are so intertwined here. Do you think that the pain causes the depression, or that the opiates cause the depression, or does the depression cause the pain?
Very good question. I think both. But I think chronic pain, that is pain longer than 3 months, will certainly cause depression. And then you get a vicious circle. You know, the depression will exacerbate the pain, it will magnify it. So I think that's, you don't have to go with amitriptyline, you can probably use some other agent, but the experts who have been doing this work tend to favour amitriptyline.
And are you looking at amitriptyline in an antidepressant dose, or just in a kind of a sedating dose at
No, more
night?
of a sedating dose for a start. And eventually you may move up to an antidepressant dose. The research that's been done on this has shown that up to 50 milligrams can be effective. And 50 milligrams is not really an antidepressant dose. It's much higher.
Would you sneak an SSRI in there, do you think, as well?
You could do that, you could add that, but I think the evidence is that the amitriptyline is better than the SSRIs for this. And you may have read recent literature or press about the fact that it's been shown that psychotherapy is much better than SSRIs. So that's very interesting. By the way, the NSAID that we like to use is Mobic. We find that's a little bit safe, and they seem to get better results with this. So there's the non-steroidal anti-inflammatory is also worth a trial. But you have to know your patient and work out who's got inflammatory back pain or who's got what you might think psychogenic back pain.
And many of our patients also complain that they've been to the physio and done the exercises and it hasn't worked. My experience often is that they've given up a bit soon, but how long would you persist?
Well, I think they should be doing exercises for the rest of their life, really, even though they may not be getting good results from them. But the exercise, people won't always respond to exercises. This is why I think you need other strategies like using heat and having breaks from their work. I think that the exercises are important, and I think one of the best exercises is swimming. So if you can get people to swim, particularly in a warm pool, that certainly will help a lot of problems, because a lot of them get muscle spasm, and you can actually feel the muscle spasm in a lot of these people, particularly around the neck. And I am not sure about the effectiveness of acupuncture, but I do know that some people who are skilled at acupuncture get very good results with treating these necks and backs. And I think if people have a trial of acupuncture and respond, I think that's a good way to go.
It sounds like a lot of West Australian shires might be applying for hydrotherapy pool grants.
Well, hydrotherapy is a great therapy. And I think that if you can combine that with an exercise program, particularly swimming, it's not a total solution, but it might be part of the solution.
Yeah.
Because everyone responds differently.
And do you have any final comments about back pain, John?
Final comments? Oh, of course, the big thing about it is prevention. Very important, the way we lift. And it's very important to have a good bed with a firm mattress. And most importantly, it's important to keep to ideal weight. Because probably most of the patients I see with low back pain are overweight. So these are the preventive measures which I think are really very important. But it's a universal problem. It's a difficult one to tackle. And I do think anyone who's got back pain, or has had back pain for a few weeks that's not responding, it's very important that they see a therapist who can give them effective spinal mobilisation and manipulation, because that has been shown to help people recover quickly from back pain. So it's worth a trial. So I think it's important for GPs, if they can't do it themselves, to have a good physiotherapist or osteopath or chiropractor who can provide that treatment.
John, thanks for joining us.
Okay, it's a pleasure.
And our thanks to Professor John Murtagh for taking the time to talk to us. Now, before we return to our studio discussion, a reminder to you to call in at any time if you have any questions or comments for discussion. The number is 1800 673 277 or 08 229 5241. Now, Tony, we're going to look at headaches. When is a headache not necessarily a headache?
Well, I guess we'll just put aside the sort of more serious pathology first. If you've got a severe acute headache, you need to think about subarachnoid hemorrhage, and if you've got a morning headache with nausea and vomiting, you need to think about space-occupying lesions, tumours, etc. So they're obviously important things to think about. So putting them aside, the more chronic causes of headaches, things like cervicogenic neck pain and greater occipital nerve inflammation, temporal arteritis, and they can be more subacute. Before we talk about those, we might just talk a bit about migraines. One of the questions was about whether there's anything new for acute migraines. The answer is no, there's not much, but probably some of the little tricks of the trade is I find a lot of people have never tried suppositories, so they end up going to the GP or the local hospital for a pethidine injection or expecting a pethidine injection, and sometimes if they have a Stemetil suppository, and then they can have their Panadol or aspirin or anti-inflammatory after that, half an hour later when they've stopped vomiting. So that's a simple thing.
What would be the dose on the Stemetil?
Usually it's one suppository, 25 milligrams.
And that's PBS listed, do you know?
PBS listed, yeah.
So
and I saw a patient the other day who'd had migraines for many years, and nausea and vomiting was a major problem because in her the triptans didn't work very well, so she ended up having a pethidine injection.
Do you have a favourite recipe then for the patient who has an acute migraine that if they have in their aura stage, you like to...
About half to two-thirds are responsive to triptans. And again, if they can't take an oral, there is Migraine nasal spray, which is on PBS authority, so they can have a nasal spray. About two-thirds of people will find benefit. It's very important they have it as soon as they get an aura. Mm-hmm. And they can have a second tablet or a second spray subsequently if the headache doesn't resolve. So if that hasn't worked, or if they don't respond to triptans, then we usually just say have 3 Panadol or 2 or 3 aspirin in one hit. Try and avoid stronger narcotic medication. Sometimes that's unavoidable. There are other options. Phenergan's a good option, either intramuscular, oral or intravenous. Mm-hmm. And some of the trials have been done on more acute management, such as intravenous lignocaine infusions have been used. One of the important things about migraines, though, is that many people don't have prophylaxis, and a recent study in Melbourne showed that about at least 40 to 50% of people with chronic migraines are not on prophylaxis. And sometimes that's because prophylaxis has failed, but often it's non-compliance or maybe doctor inertia. So propranolol is still the best agent. Propranolol has to be used for at least 3 months to be for an efficacy trial. You have to have maximum tolerated dose, and you just keep increasing it till the pulse rate's down to about 60.
Yep.
If that doesn't work, probably second line is Migraine.
So with the propranolol, a dose would be in that sort of 40 to 80 milligrams?
You start off
twice
at
a
20
day?
to 40 milligrams BD and just increase, maybe every week or two, and as long as they're not bradycardic or got other beta blocker side effects.
Yep.
So the second line is probably Migraine. It can cause a bit of weight gain.
Yep, often young women are quite concerned about the weight gain.
Yeah, the maximum dose is actually 9 tablets a day. Not many people get to that dose. But if you have 1 tablet a day for a week, that's not a long enough trial. And then third line, we tend to use agents such as carbamazepine. On authority as of last November, you can use topiramate, which is one of the newer anticonvulsants, which has been shown to improve migraines. So that's only people who can't tolerate propranolol or Migraine. Not if it was ineffective, only if they can't tolerate it for side effect purposes.
So it has a clear advantage over the older agents, or just tolerability?
Certainly not cost-effective over the older agents. So I'd always use propranolol and Migraine first, and I'd probably even use Tegretol next, and then as a last resort, the more expensive medication. For cluster headaches, we mentioned briefly previously.
Perhaps I might hold you there, just perhaps ask Declan his views on acute treatment of migraine. You must have a few people that walk in off the street and with a cracking headache.
Yeah, I mean, basically, for your long-term patients who have migraines, they can normally pick when it's going to tip to the next stage where it's going to disrupt their daily activity. And certainly, we can help to reduce the duration of that through manual therapy, so normally through upper cervical mobilisation, muscle release techniques, suboccipital release, and myofascial techniques, which will help to reduce the overall tension of the musculature around there and therefore joint restriction. And that can take the edge off it and certainly prevent it from going to a 5-7 day duration sort of migraine that disrupts the rest of the week.
Yes.
As far as walking in where you haven't seen it before, again, certainly manual traction and also upper cervical mobilisation has an effect to help reduce the severity of the symptoms. But it may certainly need to continue on with medication to control the symptoms.
In the initial stage,
yeah.
Yes. You were going to say something about cluster headaches before.
Yes, I was just going to take, because cluster headaches are quite a separate group, and in fact, acutely, they actually respond to oxygen is actually the best treatment for a cluster headache. But if that's available in the local emergency department, it's always a good option.
So
Cluster headaches tend to be unilateral, rhinorrhea and
Weepy
watering, weepy eye,
Yeah, waking you up in the middle of the night.
Mm-hmm.
How long do you have to put the oxygen on for before they get relief?
Oh, pretty well within a few minutes.
So it can be a quick and easy thing.
And again, sometimes with severe cluster headaches, we actually use a short course of steroids for a couple of weeks. But again, try to limit the course. Yeah, and it tends to be seasonal and not as chronic as migraines. One of the difficulties with overuse of narcotics and even things like Panadine Forte, because pain clinics hate Panadine Forte. That's all it does is constipate you. It doesn't do anything else. And you see a lot of people on 8 Panadine Forte for 20 years, and some of them even have codeine linctus to get their codeine. One of the problems is they get medication overuse headache, which is a huge problem, and people basically get a withdrawal from the Panadine Forte or whatever they're on, and then they get a severe headache, which is only relieved by more narcotic. And sometimes we have to admit these people to hospital, give them things like ketamine infusions to get them off their narcotic dependence, or at least wean them down, give them benzodiazepines in that period. But it's a huge issue because there's many people out there with chronic daily headaches that are purely medication related.
If you had a patient like that who was in your surgery and you were trying to give them some advice about how quickly they'd be able to turn it around from when they ceased their codeine, what's the time span?
Very rarely people can go cold turkey, and I wouldn't recommend that, but some people do it quite well. You'd usually have to reduce their medication over 6 to 12 weeks. And then the problem is when they still have their headaches after all that period, if they're off their narcotic or their Panadine Forte, that's when it becomes a little bit tricky. And again, studies have given lignocaine infusions to reset the receptors, and there's some evidence that might help a little bit. But there's also a condition called transformed migraine, where people go from chronic migraines to chronic headaches, and that's called transformed migraine. And there's whole journals. There's a journal called Headache,
Right.
and they have long debates about how to treat that sort of thing amongst neurological experts and how to classify it. So it's a very difficult area for both pain clinics and neurologists.
Do you think if you were just taking, say, 8 Panadine Forte a day on a regular basis, you're a country GP, you have the facility to admit someone, and then just stopping their Panadine Fortes, would that be a reasonable?
You could. You'd have to cover them with benzodiazepines, and they often get withdrawal, they'll get diarrhea, so they might need some Lomotil and things like that. You're probably best doing it slowly. And I often introduce things like low-dose tricyclic antidepressants, such as Endep, just to help them sleep, get them some pain relief, because they do provide pain relief. And then if you think they've got migraines, give them prophylaxis and while you're weaning them off. Give them anti-inflammatories, because they're not addictive. Give them regular Panadol. Give them Tramadol, which is less addictive. So there are ways to get people off it. But usually, as we all know, they all say they're allergic to everything except pethidine, and they're the tricky ones.
Yes.
Here's a question out of left field. What about marijuana in terms of pain relief?
It certainly helps in cancer patients. It's been shown to help nausea and possibly help chronic pain a little bit. There is a bit of evidence of problems with marijuana in teenagers now, and that causing psychotic problems. So unfortunately, there's probably no safe level of marijuana use.
Perhaps we can move on to temporal arteritis then as a cause of severe, and obviously disabling headache.
So one of the questions was just wanting to know a little bit about temporal artery biopsy. I guess the first thing is, if you suspect it, you've got to always do an ESR. It'd be very rare to have temporal arteritis with a normal ESR. It's usually, but not always, associated with polymyalgia rheumatica, and you get morning stiffness and the hips and knees. And in retrospect, people have often had those symptoms for months. The reason it's an urgent condition is because you can go blind and have a stroke. And we see people who've very quickly, within days, have had complete blindness and loss of vision. So that's why, in fact, I had a phone call today from one of the emergencies where I was on call, and the ED doctor presumed that he couldn't start prednisone unless he had a temporal artery biopsy. But in fact, you should always start prednisone if you're suspicious, and then within a week, 10 days, organise a temporal artery biopsy, which most general surgeons, some GP surgeons, and all ophthalmologists can actually do. As long as it's within a week, so it's fine.
So you've got a bit of time to be able to organise it. So if there's a clinical suspicion and perhaps a slightly raised ESR, if it was only 40, you'd still be, the sensible thing would be to commence a steroid dose and then arrange for the biopsy.
50 milligrams. If they've got any ocular symptoms, maybe 75 milligrams. So some of the tricks with temporal artery biopsies is you get skip lesions. So that means you take a biopsy and it comes back normal, and you're still very suspicious because they've got the polymyalgia rheumatica symptoms, they've got the one-sided headache, they've got problems when they comb, they've got the pain when they chew, and in that case, sometimes we have to treat anyway. And you might argue, what's the point doing a biopsy? But if you confirm it, it is good, because sometimes we get fooled. Sometimes the normal biopsy, if you read the report, if it mentions anything about the internal elastic lamina being damaged, that's a de facto sign of temporal arteritis. And the wise old rheumatologists and ophthalmologists would take that as temporal arteritis. But if you read the conclusion, it will say no evidence of temporal arteritis. So you've got to read the body of the pathology report
as well.
You can get skip lesions. You can do Doppler ultrasound to localise an area that you might want to biopsy. And if you've got access to it, MRI is quite good at finding some inflamed areas. So one of the traps of temporal arteritis, I'll give you an example of a patient we had last year, a lady who'd been to one of the teaching hospitals, had a biopsy, had a raised ESR, biopsy was negative, but felt better on steroids. Went on holidays to Italy. The doctor said, "What did they do for you back in Perth?" And they said, "Oh, they put them on steroids." So he gave her a few cortisone injections for a few days. She felt better again. Then she was admitted under me, and I thought, because she had this disruption of the internal elastic lamina, I thought she did have temporal arteritis. And to cut a long story short, after a couple of CAT scans, when she didn't get better, and a couple of MRIs, she had a lymphoma, a nasopharyngeal lymphoma. But of course, that was getting better with the steroids, because lymphoma will settle down. So if people don't get better, always think of that your diagnosis is wrong. People with temporal arteritis and polymyalgia rheumatica should be cured within 48 hours of their symptoms. So if it's 2 weeks later and they're still got the same symptoms, you should rethink the diagnosis.
Now with polymyalgia rheumatica, it takes a long while for you to reduce your dose of steroids. In temporitis, is it a similar picture?
Yes, in fact, with temporitis, you've got to give a longer course of steroids. About high dose for 1 month, and then reduce it slowly over 3 months, and probably keep it going for a year to 2 years. With polymyalgia rheumatica, we try and get them off steroids within 6 to 12 months, because what happens is a lot of people, and we've all got them, who have been on steroids for years, can't get off them. You drop 1 milligram, and their symptoms all flare up again with a normal ESR. And in fact, they've just got cortisol letdown. They're just dependent on cortisone. So, after 6 to 12 months, try and wean them off as quick as you can. So they don't end up.
But if you're not responding within 2 weeks, think about further
something else.
investigation.
Yeah. And that's when you send them off for MRIs, etc.
Yep. What about the non-migraine headache? Declan, perhaps you've got some advice.
Quite a few patients would attend with either tension type headaches, where the kind of definition would be more that it's a pressure type headache rather than a pulsating headache, which we get with a migraine. And this can be associated through postural dysfunction, compression, loading at work, as well as aging processes, so arthritic changes in the mid to upper cervical spine and preventing normal range of motion within the cervical spine. So basically, from our point of view, we try and look at the bigger pictures and see, rather than just looking at one symptom, see what else is involved in there, particularly with your postural dysfunction. The shoulder girdle can be involved. It could be a work-related issue. Is there other things we can do to change those environmental factors as well as the intrinsic factors such as muscle strength and range of motion?
So any specific exercises that you without being having a particular patient in mind, or
I mean, typically,
too hard to?
Well, yeah, I mean, I would try and prescribe the exercise specific to the patient, but certainly for your postural dysfunctions where people are computer operators using mouses, generally is a depressed scapula, so normally the elevated scapula posterior scalenes are overactive. Upper trapezius can become inhibited, and therefore you want to kind of create that symmetry back again between the shoulder girdles, so you want to do active shoulder elevation to stimulate the upper trapezius, perhaps some interscapular resistance exercises for serratus anterior and lower trapezius, just to help correct the shoulder girdle position.
Yeah, I think that.
Well, on that note, given that we're now looking at these kind of things, we may as well have a look at a demonstration of some exercises and manipulations. Now, Declan, can you just give us an overview of what we're going to see in this?
Basically, this demonstration was with the model is a physio who I work with who has a dysfunctional right shoulder caused by, as I was just saying there, an overactive levator scapula. So basically he has a depressed right shoulder girdle, loss of range of motion with rotation to the right, and basically we're looking at basic techniques that you can use to correct it.
All right, let's have a look at that then.
Declan, in general practice, a lot of patients turn up with neck and back pain. What are the common things that you see?
Well, typically at this time of year, with the cold weather, we generally see a lot of what we term as a wry neck, which can either be traumatic, which affects predominantly the upper cervical part of the spine, which can affect the disc, or the plica, which can become trapped, which restricts the movement of the facet joints. More commonly, we see what I personally term as a pseudo-wry neck, which is more muscular in nature and affects more the mid-cervical down into the shoulder cervical complex. This will manifest itself as increased muscle spasm, a loss of range, particularly to the affected side, and occasionally headaches as well.
So are they the patients who do a lot of desk work, or is there a particular...
There is a correlation between sort of postural effects long term, but sometimes you'll get an insidious onset where there's been no recorded history, there's no previous pain, but certainly the cold temperatures, the sudden spasm, a cough or cold leading up to it where you've been sneezing a lot may lead to a wry neck to occur.
So what would you see if you were going to try and diagnose this?
Well, Jim's particularly good dysfunctional kind of physio patient who has a right-sided problem. This is a long-term problem by the way it manifests itself, that he has increased tightness of the pectoral muscles, which allows his humeral position to drop forward. He has some inhibition of his upper trapezius fibers and has increased activity of the levator scapula. This results in tightness and pain and restriction to his upper cervical spine. This we can see just by looking at standard range of motion. So just turn your head to the left there for me, Jim. You see we've got a relatively good quality of movement. He's not cocking his head to the side. A little bit restricted, just generally due to his rounded posture. And facing forward again for me. And now this time to the right. As he brings his head across, you can see a restriction beginning at the mid-cervical with a slight cocking of the ear towards the shoulder. This is typical of the levator scapula being overactive. And facing forward. Other muscles that are normally involved with this, depending on the long-term nature of it, where you get adaptation of the muscle and compensation reactions, are the posterior scalene and middle scalene, as well as I said before, the pectorals become tight, allowing a downward rotation of the scapula to occur and a lateral migration. Long-term, left untreated, may result in an impingement of the supraspinatus tendon, but immediately what we're looking at is mid-cervical pain and headache.
In a general practice, what would we look for and how would we start to treat this?
Well, initially, as I said before, the range of motion is quite a key element to it. The patient will have reported either an insidious onset of pain, just woke up that morning getting out of bed, or recently they've had a viral infection but have been coughing and sneezing, which may suggest an underlying disc as well. So typically when you're looking at a patient from behind and from the front, you're looking for symmetry. In Jim's case, we have a downwardly rotated scapula, so we've got a flattened cervical lateral curvature comparative to the normal curvature here. We get an increased activity of the levator scapula on palpation, which when we press will cause some discomfort comparative to the other side, which is nice and relaxed. If you were to look at the medial borders of the scapula, going by spinous process, this is a rudimentary sort of observation, you can measure and see just what the position is and looking for symmetry. With Jim, we can see a loss of tone, lower fibers of trapezius and serratus, allowing the scapula to kind of wing away from the thoracic spine. Palpation of other tendons such as the supraspinatus may elicit early signs of an impingement.
And how would you start treating this?
With Jim being a chronic situation, exercise is probably paramount, given that there may be an underlying instability due to long-term changes with the muscle. So with Jim, I'd try and correct his rounded posture by first of all getting to actively recruit his upper trapezius by getting to shrug his shoulders up towards his ears, holding for a good 5 to 8 seconds. Then
When you say correct their posture, you mean you
So
get the patient to hold
actively-
their shoulders back without externally rotating?
What we're trying to do is trying to facilitate and increase awareness of where the shoulder blade should be in relation to the rest of the body. If there is other long-term changes such as pectoral tightness, which is causing increased humeral rotation, internal rotation, then you may need to address that first by stretching out the pectorals. So initially, just actively correcting the patient, the scapular position for the patient. You may need to do this a few times, but with Jim, being a physio, he has a certain level of awareness, and then bringing it in, and then getting to actively elevate.
How much time or how many times would you get a patient to do that and for how long?
Well, we're aiming for the slow, controlled movements. So in standing, it may be difficult for an average patient who has low awareness of the scapulothoracic region, so you may need to get the patient lying down, and you can work on guiding the scapula for it. Might just get you to lie down there for me, Jim. Don't mind. So in this position, we can check to see the accessory movements for the upper ribs, to see if there's any involvement with the posterior scaling. We can mobilise the upper cervical spine, but as I was saying before, we can actually start to facilitate and guide a scapular movement into a neutral position. What we're aiming for is a kind of an angular position heading towards the spine, so we're recruiting lower fibers of trapezius and the serratus anterior. We're trying to control a winging motion so he's not flaring away from the chest wall. And relax down there for me, John. Whilst facilitating, you'll be able to palpate and feel different things like crepitus, where the clavicle has been grinding against the acromion from long-term chronic position of the depressed shoulder. And occasionally, where the ribs have been hyperinflated position, you'll get the sound of the shoulder blade rubbing over the ribs as well. And just slowly bring it back again. So the aim is just to allow Jim to get it to a normal position, then we ask him to assist by
Okay, so that was you moving
Mm.
to start with.
And then we'll see if Jim can hold it there. we're looking at this area, seeing what's happening within this lower fibrous trapezius.
And so this is where you're expecting the contraction to be?
It should be.
And how long before they will fatigue?
Initially, depending on how long the patient's had the problem for, it can fatigue very quickly, even within about 3 seconds. And so you may only get a patient to do 3 or 4 repetitions of this as an exercise before having a break and coming back to it in half an hour to an hour. So just try that again without me helping you there, Jim. So classically, on its own, Jim lacks that awareness here, so he starts to pull down and then pulls across using a lot more middle fibrous trapezius and rhomboids, which is then walking out through here. He still remains relatively soft through here, which is good, and then slowly down. But you can stimulate it by rubbing the skin, just to provide a bit of feedback, a bit of proprioception, and that already starts to improve the contraction. Still recruiting through there, but not as much.
If the patient only has this problem on one side, or their pain on one side, do you get them to do both?
Yes, because you can get overflow happening by stimulating both sides of the body at once. Sometimes you can get a better quality so that the patient may be able to increase their endurance.
All right, so both at once rather than one at a time as well.
But you're aiming for functional control, which would be if Jim was operating a mouse all day, he'd mainly be using the one shoulder. So we want to be able to, for him to use this independently as well as at the same time as the other
About
exercise.
how long would a patient have to do this sort of exercise before they saw some real improvement?
Realistically, you would notice an improvement within a week. There's 3 real phases to the motor control sort of retraining. You've got your cognitive phase where you have large improvements over a very short period of time, but require a lot of concentration and focus on the patient's behalf. Once over about a 2-3 week threshold, depending on the patient's cognitive ability, they move into like an associative stage where they can start to multitask, start doing it consciously with work, but it will still fatigue quite quickly, but the improvements become a little less frequent. So it's more like a polishing stage.
Yep.
And then hopefully, automatically, it will become an automatic function, but that varies on the patient. Obviously, if there's a headache component to the shoulder neck problem, then we may want to look at the upper cervical, and if it's purely a headache, you may want to look at it from the front, so you're doing an anterior-posterior mobilization to help stretch out the capsule and the muscle attachments. Certainly, if there are headaches and shoulder pain, you want to look at neck and rib and shoulder to rule out which is causing which.
So, Declan, this sounds like an area in which GPs can really work together with physios, so thanks for demonstrating that.
No problem.
Declan Coburn at work there. Now, Declan, are these the kind of techniques that a GP could do, or is it something that you would prefer them to refer to a physio specifically?
Well, those techniques are certainly quite straightforward, and using powered observation and some good, keen hands-on practice, there's no reason why you can't develop those skills. But certainly for further, more complicated tasks, then yeah, it's worthwhile referring on to a specialist.
Would you have any other sort of muscle energy techniques that you could perhaps recommend for the treatment, say, of a wry neck?
Yeah, I mean, basically with wry necks, it's generally unilateral, so there's normally lots of associated muscle spasm in the area, and self-mobilization, sort of hold relax techniques that patients can do, sort of, if pain allowing and restriction allowing, they can mobilize the neck for scalene activation, so taking the neck into an opposite position, applying a gentle resistance whilst pushing the head back against the hand, holding for about 8 seconds to 10 seconds, and then relaxing off, repeating 4 times. Generally, after applying a heater, it's good to give the muscles enough blood supply to help to relax there. And certainly, you can mobilise the neck with rotation, so you can do like an antagonistic approach. So basically, if you restrict to going to the right-hand side, you may wish to resist going to the opposite to cause an inhibition of the overactive musculature.
Yeah, and you get a good success rate with that.
They're good self-management techniques that I can give to patients to continue with as prophylactic advice, and also to maintain the benefits of the treatment session that they've received that day.
Tony, could you perhaps fill us in a bit more about some of the injection techniques we might use in with headaches, perhaps with great occipital nerve injections, for instance?
Yeah, I guess that's right. Starting off at the top of the neck, the greater occipital nerve is a bit forgotten about, and I know I had a patient earlier this year who'd been to ED 3 times and seen the ENT clinic twice with headaches, and they were really predominantly greater occipital nerve. And classically, you just push on the back of the occiput and they're tender, and the pain is sharp, neuralgic sort of pain radiating to the front, usually unilateral. And you can try anti-inflammatory gel, diazepam if they've got muscle spasm, anti-inflammatories, neck exercises, but it's a fairly localised problem and it often needs a cortisone injection. And you just basically use whatever cortisone you're used to with some local anaesthetic, go under the skin and just get a mil or two on either side because the great occipital nerve sort of flares out just at the bottom of your occipital notch there at the back. And it's often quite effective. This lady gave me a bottle of red wine, so it was a bit of a bonus when she was fixed after having pain for months. Further down, you can do cervical.
Just holding there for if there is a particular sort of type of precipitant for an occipital nerve headache, is it going to be your typical young man rugby player, or is it more?
No, I find it more middle-aged people. Much more common, and it seems to be like an inflammatory localised, and it usually comes on slowly subacutely over a few weeks, but it can be very severe.
And other times it can be post-traumatic, say post-motor vehicle accident, where there's an instability segmentally which causes kind of protracted head and neck type posture and allows for extra hypermobility in the upper cervical spine.
And tugs on the nerve and then leads to the problem.
Yep.
Okay.
So, and further down, you can do cervical spine injections. Always got to be under X-ray or a CT guided control. They're usually only useful if you've got a very localised, like if you've only got C4-5 facet joint pain, and I certainly have seen some people have excellent results where they've got severe cervicogenic migraines originating from their isolated neck arthritis. So if they've got multi-level disc disease, there's not much value, but usually in conjunction with the radiologist you can find the worst affected point. And then further down, thoracic injections we probably don't order as much, but certainly lumbosacral injections, and it's important to realise there's nerve root injections, sleeve injections, and less commonly epidural steroids are still occasionally used by anaesthetists. But the localised injections work quite well, and they can last for 3 or 4 months. You can't repeat them too often.
And that's the facet joints, or is that just injections in general?
Yeah, so usually you get a picture from the radiology report, and if you're not sure, talk to the radiologist, and they'll organise it for you. And so they often decide where the pain's coming from, and they're better at localising it when they put the needle in, so localise it with the patient.
Yep. With we've been talking a bit about manipulation techniques. Would there be any times when you wouldn't want to manipulate, or some of the possible complications of manipulation?
Yes.
Perhaps we should talk about that for a moment.
Yep. Well, we'll get Declan to talk about because the physios are very good at who not to manipulate. But I guess the main risk is dissection, and the data is a little bit fuzzy because the problem is people have a pain and they go to the physio or chiropractor. Now, was the original pain the dissection, or did the manipulation cause the dissection? And we don't really know. There's no doubt that some people get a tear from the physical manipulation, but conversely, they may have already had the dissection. And also, as I said, I've seen quite a few people who've been told not to have manipulation by the physio or chiropractor, gone on to be investigated and found such things as dissections.
It's sitting already there. Have you got any tips for patients you don't want to see?
I always want to see patients, so I get it right. But basically, when we're looking at manipulation of the cervical spine, we, as physiotherapists, really have to go through a checklist looking at vertebral artery testing. We also, for yellow flags, older patients where there may be interforaminal stenosis, and also osteoligamentous disruption from previous injuries, that we may send for further investigation first, whether it be X-ray or CT. Red flags would be certainly looking at tumours, recent viral infections, would be kind of a crossover between yellow and red flags there, where there's increased play and laxity within the ligamentous structures, which may affect the quality of the manipulation and therefore the outcome. But generally, as a rule, as long as we follow the guideline, that we're not reproducing nystagmus with vertebral artery testing, and
yes,
that we're clear on what we're doing, that
then you can be pretty sure that you're not going to run into problems.
Pretty much.
Yeah. Was there any other new drugs that you'd like to mention about with specifics to headache treatment?
Yeah. So in terms of nerve pain, most of you have probably heard of the newer agents gabapentin and pregabalin. In fact, gabapentin's so well marketed as for neuropathic pain that some of my registrars don't realise it's actually an anticonvulsant. But of course, it's not on PBS. It is available on REPAT, and pain clinics love gabapentin. They use a lot of it. You've got to accelerate to a fairly high dose for full effect, and certainly it's got less side effects than tricyclic antidepressants and the older anticonvulsants. I'd still use tramadol or tricyclics or carbamazepine first, but when they're not working or not tolerated, gabapentin and now pregabalin are very effective. I think the cost for pregabalin is about $80 a month for a private prescription. Some people are quite prepared to pay that. I'd always give people 2 or 3 weeks of a trial. Usually, most people have samples in the office. Sometimes HBF will pay for some of the. I think they'll pay about $400 a year for the patient.
And how quickly would you accelerate the doses? Obviously, a high dose range.
Yeah.
So
after about 2 to 3 weeks, you start accelerating. Yeah.
So you might start at, if you, for instance, with gabapentin, you might start at.
Well, you start at fairly low dose, about 100 milligrams TDS.
Yep.
But a lot of people don't realise the maximum dose is actually 800 milligrams QID. So it's 3,200 milligrams, quite a big dose. And some of the pain clinic people absolutely get up to those levels, and it costs about $200 or $300 a month for.
So the $80 a month is.
$80 a month is more the basic.
300 milligrams.
Yeah, so pregabalin works out on the higher doses, or I should say the maximum doses. Lyrica works out quite cheaper. Gabapentin, if it is equivalent in the medium dose range. When you're getting to 800 milligrams QID, it's quite expensive.
But you might accelerate that dose on a weekly basis, or every 2 to 3 days.
Probably every 2 to 3 weeks. Yeah.
Every 2 to 3 weeks.
Yeah, a bit slower. Yeah, because of side effects. And I do find that some of the chronic pain people who get side effects from other anticonvulsants still get side effects from gabapentin and pregabalin.
Thank you. Is there any other particular headaches that we think we'd like to mention? There's obviously jaw pain. Is there any particular physio techniques for people with a dodgy TMJ?
Well, with TMJ symptoms, you'd normally be looking at sort of Syriac type approach, where you're doing resisted jaw closure, but taking it to full extension first, and basically resisting it with your hand. Equally, the patient can do sideways pressures resisted on both sides, and also jaw protraction and retraction techniques. But generally, sometimes TMJ pain can be crossed over with overactive sternocleidomastoid, anterior scalene tightness, which can be relieved through manual techniques and upper cervical joint mobilisation, particularly anteriorly.
Mm-hmm. And what about the sort of trigeminal neuralgic sort of type pains that patients might present with rather bizarre symptoms often to start off with?
Yeah, that's right. They often have pain, cold sensation. Never forget about dental abscesses. Mm-hmm. Some people have on tricyclics and Tegretol for weeks and weeks, and they're evaluated by a dentist and they've actually got a dental abscess, which is easily cured. So excluding dental pathology, then after a few months of trial, if they're getting worse, they probably should be referred to pain clinics, because there are injection techniques. I think it's a spheno palatine block they can do. And then there's also neurosurgical procedures where the surgeons get in there. I think it's called a Jenner's procedure, where they actually get in there and release the trigeminal nerve. Obviously a lot more invasive. And most people get better over 6 to 12 months. But the patients will all tell you it's a severe lancinating pain, like a lance, and it's incredibly painful at times. I think it's one of the worst pains that you can have, similar to the sort of post-shingles pain. And sometimes the capsaicin cream can help as well.
Mm-hmm. And that's not just because it's so painful that you completely forget about anything else?
It does, that gate theory of inhibition that Declan mentioned earlier, it probably does act via that pathway.
Yeah.
And it can only be used for weeks to a couple of months. It can't be used forever.
What about acupuncture as well? We haven't spoken about that this evening, but I would be interested in your views on where you think acupuncture falls in. Perhaps start with you, Tony.
Well, I guess there is good evidence that it works in certain conditions, and that's fairly well documented. I think it has to be done properly and with a well-trained person, and similarly acupressure I think has got some evidence as well. But I would always rather people have acupuncture than chronic narcotics.
For sure. And acupressure techniques?
Yeah, I mean, at our practice we use both traditional Chinese acupuncture as well as dry needling type techniques for myofascial release in trigger points, as well as obviously hands-on manual therapy. We're predominantly a manual practice. And so they do provide some good relief in chronically overstimulated muscles, such as the levator scapula, also calf muscle, tennis elbow sort of symptoms as well. So there's certainly a key role for them there, without having to resort to stronger opioid type medication.
Narcotics, yes.
Yeah.
Any thoughts about when we do get to that patient that really is suffering with a pain that you want to be able to give some relief? Do you have any particular narcotics that you would steer clear from, or some which you like more than others?
Well, generally, OxyContin is fairly well tolerated, and MS-Contin. Another option now is the Norspan patch, Temgesic, and I, like most people, was probably a bit sceptical when they came out about a year ago, but I've had a few patients done very well on them, and fentanyl patches are available for chronic pain now. So some of the problems are, at least certainly overseas, are the abuse of OxyContin. It's called hillbilly heroin now. It's actually more commonly abused in America than heroin, and the street trade in OxyContin tablets is huge in Sydney apparently.
So it's probably best to try and avoid that.
Yeah, best to try and avoid. And the patches, they have also problems in America with people putting too many patches on and getting overdosed.
Okay.
And some people get a bit allergic to the patches, a bit rash. But certainly, there is a value, there is a use for narcotics. Yeah.
Thanks very much.
The good oil and the good drugs there from Tony Ryan. Well, that's all we have time for tonight. If you'd like more information about the issues discussed in tonight's programme, here's a couple of resources that might be useful to you or your patients. There's some good information about avoiding migraines at www.nomigraines.org. And for information on all types of headache, you can visit www.headacheaustralia.org.au. Both those links, along with others, will be posted on the Rural Health West website. And you'll also find some fact sheets showing some of the simple preventative exercises shown and discussed in the programme tonight. Any final thoughts, take-home messages, gentlemen? Tony?
Yeah, maybe one last message. Never forget osteomyelitis. We see people who've had low-grade fevers and back pain, raised ESR for up to 3 months, I've seen it, and in an ankle I've seen it for someone have symptoms for 12 months. So never forget osteomyelitis.
Declan?
I guess with most spinal sort of injuries, pain is to remain mobile and try and keep as normal and active function as possible without immobilising.
Keep on moving. Don't forget, if there's any part of this programme you'd like to review at a later time, a delayed transmission of the Rural Doctors programme will be available via internet web streaming next week. And this service is accessible through the Rural Health West website at www.ruralhealthwest.com.au. And note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West on 08 6389 4500. And it's also worth pointing out that those broadcasts are now available for download from the Rural Health West website as either a video or an audio podcast, so you can download the programs and listen to them at home or in the car. Instructions for downloading the podcasts are available by calling Rural Health West. We'll be back again on the 5th of August with the programme for you focusing on causes and treatment of growth disorders. We look forward to your company then. From Dr. David Jemison. David, thank you for being with us.
Thank you very much.
Tony Ryan and Declan Coburn. And thanks to you for taking the time to join us tonight. Good night.